t-shirt, you need to start to write it to us and we're gonna send it to you. The second thing is the custom surgical people were so good to us, and with the community actually, that we're gonna give one away. We're gonna give one MicroREC away, and there is very interesting discounts for people who can connect now. Okay, so it's gonna be great. Be in touch and you can win one. The other company that is very good to us is Bionico. That's gonna be giving away $500 in these models that we use a lot, not only to train basic skills, but also to train new techniques or complicated cases. So after I say that, I'm gonna start here with the slides. It's gonna be great. Welcome everybody. Welcome to your patient's view. These are 4 webisodes that are connected so you can improve your practice. Who are we? Well, we are an authentic community trying to share the best tools so you can improve your practice, and then when you improve your practice, you can improve the quality of life of your patients with the best technology. What's going to happen today is with this structure. We're going to do the 5-minute show, and we're going to present each other. We're going to do the mask event. There's going to be 3 surgeries that you will don't know who the surgeon is. Then the academy is about finding the best evidence to apply to surgery. Amazing topics that we're going to discuss. And finally, communication and education. We're going to talk about how you can communicate and educate better in a surgical environment. Let me present the amazing panel. For me, it's a complete honor to be here with Dr. Vito Romano from UK, also part of ESASO, somebody who really likes to do teaching and to do a lot of communication. Vito, thank you for being here with us. Dr. Domenico Boccusi from Italy, also an expert in this matter. We're going to learn a lot from him. Montserrat Garcia from Spain, thank you so much, doing amazing things in surgery. Dr. Norbert from Hungary, also thank you very much, an expert and a lot of experience to share with you. And Dr. Ramin Koramnia from Germany, also sharing a lot of knowledge with you guys. Let's start quick. And let's start with the 5-minute show. In the 5-minute show, I'm going to say 5 important things. The first is going to be the interdisciplinary team we have behind this. A lot of people, but people from academy, from industry, doing branding, doing software, doing research. We have Dr. Lisandro Carnielli behind the scenes doing magic, not only in videos, but in many other areas. We thank him very much. We have this in the scenes. We have 6 colleagues translating this into French. Dr. Aymane Tarib, Mohamed Hissem to translating to German, Cesar Vilar to Portuguese, Luz Marina Melo to Spanish, Chiara Angeli to Italian, and Karen Masmanian to Russian. Thank you so much. These guys are so important today. Thank you very much for being here with us. And let's start with a quote. And I think it's very important about, in this 5-minute show to talk about humans, to talk about the cognitive abilities that we need to have in this example, for example, to talk about surgery, with an open mind and with willing to learn. And the other thing is that something that differentiates ourselves from other species is this way of cooperate in large groups with unrelated individuals. Another important thing in the 5-minute show is the ambassadors. We have one young colleague from every single country in Europe helping us to reach their countries to talk about their realities that sometimes are completely different from other realities, because Europe can be a little heterogeneous, right? We are also doing a survey, and that's the QR. If you didn't answer it, I'm gonna just make it a little bit easier for you guys, so you can go to that QR code and answer these questions. It's 5 minutes, but for example, it's giving us this insight. Look at this. We are seeing that people are extremely comfortable performing surgery. However, when we ask about data, about tracking measures and tracking about what's happening with different parameters, they're not feeling so comfortable. So I think there's a lot of area of opportunity in that matter, and that survey is giving us a lot of information that we're going to discuss in the last event, event number 4. That's very, very important. This is our mantra for the year, adding value to your time. This means that we talked with the panel before we started, and we have one mantra today. Every time we open our mouth is to add value to your time. So we're going to talk only to transfer knowledge and skills. This is very, very important for us. Another slide that it's very important for us is here, and we're working very closely to the Alcon Experience Academy. You can see the QR code there, and you can enter to the Alcon Experience Academy. That is an amazing platform always for us to learn. And we believe that industry and academy are going in the same direction. We're going in the same direction, and our goal is the same, and is better outcomes to our patients, better quality of life for them. So today we're going to have a mindset of collaboration, and we're going to learn a lot from them, and they're going to learn a lot from us. In this also equation, it's ESASO, and we thank them very much to be part of this. Again, 3 organizations who really like to educate, and with one objective, that is skill and knowledge transfer. The last thing before we start with the mask event is to talk about the perspective we want in an event like this. So what we want is a new perspective, the perspective from the patient. And here we're going to have Shamien Labetsky from industry, as we were talking in the past, to help us to understand this new perspective from our patients. Shamien, thank you for being here with us.
Thank you so much, Ivo, to you, to Ophthalmo University, the whole team. It is an amazing community, and I really look forward to talking about patient education and communication later on in the show. So thank you so much.
Amazing, amazing. Yeah, we're going to learn a lot from you. And finally, one of the quotes I like, you know, they say, well, this is, I'm putting it away, but this guy is Tim Grover. And as you can see there, he was the trainer of Michael Jordan. You probably know Michael Jordan. And I think he was one of the main elements to make Michael Jordan who he was. And he will say that you are as good as the tools you have chosen and the ability to use them in their maximal potential. So today, we're going to specifically talk about these 2 tools. We have a Panoptics and a VVT there rotating in our operating room. And let's see if these tools can improve our practices and also can improve the quality of life of patients. Remember, these are 4 connected webisodes. We did already number 1. It was amazing. You can find it in many platforms, in the YouTube channel of Ophthalmo University. Number 2 was also excellent. We talk about the pre-op. And today, well, there's a lot of people excited about today because today we're talking about surgery, right? And everybody loves surgery. But remember, webisode number 4 is going to be very important. We're going to do amazing things here in the Ophthalmo University campus in Mexico City. We're going to talk about the consult. We're going to give the prizes away, so don't forget to come to webisode number 4. And to prepare the audience, you know, there's going to be a lot of discussion today, and I think it's a good moment for us, as we said in the cognitive abilities, to fight our biases. Okay, today is a moment to be open-minded, it's a moment to share knowledge and to try to learn a little bit from everybody. And in honor to the amazing Italy, we have some masks from Venice there, and we're going to do the mask event. What you're going to see is 3 surgeries from 3 different surgeons, and then we're going to guess who they are. So we're going to go with surgery number 1, and well, while we're seeing it, we're gonna enjoy it. So please, vamos a poner la número 1. Very good. And let's start, guys.
Implanting a new technology Vivity, an EDOF multifocal lens, needs preoperative measurement, accuracy, and surgical precision. Those are crucial to good outcomes. If you can't deliver a perfectly emmetropic eye at the end of the surgery, you have no business implanting a multifocal optic IOL. For and foremost, you have to do everything in your power to maximize the optical result. In reality, the outcome of multifocal surgery is determined before the surgery rather than during the surgery. If you can execute what you have planned to do and obtain the predicted result, you will have a very happy patient. In premium IOL surgery, we must hit the target refraction precisely. So, to achieve this goal, we need a very well-centered, well-located, and a round capsular axis. Whatever you do, you must be very precise in every action. An incision of 2.2, where it is located limbally, is something that you want most, because this kind of incision is somehow astigmatically neuter. So, after having a good incision and after an excellently located capsular axis, you are going to emulsify the nucleus. There are many ways to emulsify the nucleus. You can do, well, divide and conquer. You can do many chopping techniques. And in this video, I'm going to show you a new technique called crater and split. With least occlusion, pieces are aspirated without getting into a state of occlusion, and emulsification should be carried out on the outer surface of the nuclear pieces. This avoids heating the anterior chamber. We know that heated anterior chamber leads to inflammation. As we are proceeding with this nucleus fragmentation, we must be very careful to remove the core of the nucleus. You can easily break the peripheral part of the nucleus, which is not an issue. And once the nucleus is divided into pieces, you are now ready to carry emulsifying the free material. Never to forget, if you are using torsional energy to avoid occlusion, you have to aspirate the material simply staying on the outer part of the nuclear pieces. If it gets occluded, simply help with your chopper to emulsify the material. Meticulous cortical irrigation aspiration is a must. A bimanual polymer INA tip adds to the safety of the cortical removal. In these cases, centration is extremely important when implanting a premium IOL. You can benefit from first and fourth Purkinje images as you are implanting your IOL. A larger pearl is use of sophisticated device, the Varian digital guide, which allows the surgeon to measure the center of the normal pupil and the axis of astigmatism before surgery. Video overlay is displayed on the surgical monitor or in the operating microscope. This overlay provides the exact axis of the corneal astigmatism, size and the position of the capsulexis to be performed, and the ideal position of the toric.
Hope you're also enjoying the video, and it's going to be one question. We're going to have one question for the audience, okay?
Now we are going to implant this VVT lens.
It's very interesting to see the technique. It's a technique that I really like for head cataracts. And also to see the IOL he's going to implant.
By manual injection of the IOL into the eye. And with a great control. Yeah.
It's very important then for us for you to answer what the surgeon is going to do next, okay? And why? Because it's a very interesting point when we're talking about multifocal IOLs. So please, let's put the question to the audience in Zoom. There you go. You can answer. What do you think the surgeon is going to do next? Let's try to make it very efficient and fast. There you go. Let's see the answers. And we're going to keep showing. Very good. Very, very interesting. 48% of the colleagues are talking about centering the IOL. Very, very interesting. Also, of course, talking about aspiration of the viscoelastic. That is something that we always need to do, and in a very precise way in this patient. Let's keep the video.
You now know that if
Excellent.
you put the lens properly, and if you remove,
and then I want you to see, and I think it's very important here, how the surgeon has augmented reality, in this case Varian, to make a perfect centration of the IOL. As you can see in the reflex, it's a VVT IOL. Excellent. Look at that perfect centration of the IOL. We're going to talk also about the importance of have this kind of lens completely centered. So let's go to the panel. Let's discuss with this amazing panel. First, we have a very interesting guest from Turkey that I will love for him to comment this surgery. Doctor, are you there? You have some comments about this amazing surgery?
Well, thank you very much for giving me this opportunity to meet these fantastic people from all around the world. It's really a great pleasure. Well, the video mainly discusses 2 points. Number one is saving the material in the anterior chamber. I'm very skeptic about being very careful about the safety of the surgery. Not only tearing the posterior capsule or doing harm to the anterior chamber structures, but also the inflammation that may cause some other issues in long term. So to avoid this inflammation, it's better to avoid occlusion, and I always propose using occlusion-free phaco. Occlusion is the enemy for this. So to avoid occlusion, it's always better to shave from the outer part of the material that I wanted to emphasize with this video. Number 2 is at the end of the surgery, we always check our cases, whether we have done a good job for the patient simply by getting MTF values and point spread function values of the patient's eye after the surgery. We realized that a not a well-centered IOL is not a good thing for the patient. So to avoid this unexpected final outcomes, we paid great attention to centralize the IOL. But in order to make a good outcome, you have to remove all the viscoelastic behind the intraocular lens so that you can put and centralize the lens at the place wherever you put. If you leave the viscoelastic behind the lens, even if you centralize it, it is not feasible at the end of the surgery to keep that IOL in that place. So it's simply because this kind of lenses, these hydrophobic lenses, leads to fibronectin production in the capsular bag. And if you remove the viscoelastic, it sticks to the capsule. The second thing you can benefit is the Purkinje images. If you center these Purkinje images, number 1 and number 4, with your one eye, looking with your one eye, then the likelihood of centering that lens is very high. Of course, if you are using a digital navigation device like Varion, it will even help and make it more precise.
Very interesting concept, doctor. Very interesting. Thank you so much. And I think we're making a very important point about something that we don't talk that much. You know, we like the technique, we like the incision, we like many things, but I think that's a very, very interesting point. And I would like to see, by seeing the surgery, Dr. Vito Romano, what do you think? Do you use the same technique? The incision, as we saw, was very, very scleral, so there's not a induced astigmatism. How are your thoughts when you're putting premium IOLs?
Yes, I use the same. Thanks. So first of all, thanks for the invite. Thank you for organizing all these amazing event. I use the same technique. I do a scleral in incision that is very scleral because I think the healing is a bit better and it's a less astigmatic. And I use as IA, I just one, so from the main incision, because it's one monoaxis, coaxial. And the other things, the centration, I think Varion is the best instrument that you can use it. The question is, when you don't have it, what do you do? This I will bounce back to you, this question.
Excellent, excellent. Dr. Ramin Koramia from Germany. We know that you are very used to high technology in intraocular lenses. Tell us a little more about your surgery.
Yeah, so basically when I started surgery, I really started right away using the Varion, and I can really say that this facilitates implantation, especially of these premium intraocular lenses. Regarding the incision, I would say that I sometimes do that somehow differently, because when I use the Varion with a non-toric lens, what I really like to do is to place the incision on the steep axis, because if there's some small residual astigmatism left, I think that this is a very nice way to address the astigmatism. So I don't always target for a completely astigmatic neutral incision. Yeah, so I think that in some cases, when you position the incision very nicely, you can actually get a better result in your patient. One question that I actually had to the surgeon in that surgery was regarding the use of the Varion for the capsular axis, because I really think in the cases where I don't use femtosecond laser technology, I also like really the overlay of the 5mm rexis, yeah, to really make sure that I consistently create a rexis of 5mm. And if you have that device, I just was just wondering why you didn't make use of that function.
Well, we don't know who the surgeon is yet, but I think the first surgeon who commented the surgery had a very similar accent to the one who was describing it, right? We're going to see that in the past, but I think it's a great idea. Just to finish with this surgery, I would like to ask Dr. Norbert about the technique. We always, try to use a good technique to the fracture and the nuclear extraction, of course, to take care of the endothelium and the posterior rexis. What are your preferred techniques in these cases?
Well, I haven't known still this moment on this technique used by Professor Aslan, but I use a very similar one. I think this technique is better in a harder lenses, harder nuclei. I used this quite similar one, but I do not bore a hole in the nucleus. I just drill in and make a counter strike with my chopper without using vacuum and without using torsional or longitudinal power, phaco power. and it works. It's like similar the technique which was introduced by this famous Japanese Akahoshi professor, but without using special tools for it. You've got your chopper and you've got your phaco-tip, and you are quite experienced with both hands with this bimanual technique. And it is, I can say that even in harder cases, in harder nuclei, you can reduce significantly the used power for the removal of the nucleus and cataract. And next day, it was very surprising if you use these techniques, even harder nuclei, the cornea of these patients were very clear. They got over 0.8 or even 20/20 next day. It was astonishing, even in white cases, in white lenses. First. The second one, removal of visco OVD is a must. I think that using capsulorhexis for the variant used for capsulorhexis, I used this in 2016, this technique. The problem is that variant hasn't got this 7D or 6D technology like excimer lasers. So it projects you this circle directly on the lens. But if you slightly roll the eye, this projection is contorted slightly. And in this case, your capsules can't be so round. So I use this capsulorhexis projection for that purpose, to see exactly how big, what kind of diameter of my capsulorhexis should be performed. And I always, if I have a round pupil, I follow the pupil edge when I drive my capsulorhexis. So I very much appreciate this lens technique, lens removal technique. And that's my opinion in this case. So it's number one. Perfect. It's number one.
Thank you very much. Thank you very much. Let's go to surgery number 2. It's going to be very interesting as well. And we're not going to have audio here because we have somebody very close to the surgeon who's going to help us identify who the surgeon is. So we're going to see the surgery and we're going to discuss a little bit what we're going to see. Thank you very much. And also remember, guys, I think we have a professor very important here, the speaker, if you wanna change the way you see it in Zoom. We are seeing now the main incision, and it was done with a blade. I think that's very important, something to discuss. And here we're gonna stop and ask the audience. The femtosecond laser was done, and then the surgeon did the incision. So what happens next, right? We have the capsulorhexis done. And we would like to ask the audience what they're going to do next. They want to inject dispersive viscoelastic or cohesive viscoelastic, or perform the capsulorhexis, or just extract it. So take a few minutes to answer. And this is going to be one of the interesting things of the surgery. And we have somebody here with us that is Doctora Montserrat Garcia, who uses a lot of femtosecond laser surgery, and I think he's used to this kind of surgery. What can you tell us? So what we saw so far, Montserrat?
Hi, Hugo. Hi to all the audience. Yes, in our clinic in Madrid, in Clínica Armentería, we have 2 femtosecond lasers, Victus and Lensex. And we offer this surgery for all the patients that are candidates for a premium IOL, because we think that the final result it's much better. As you can see in the video, one of the most important issues in our cataract surgery is that with both Victus, that this video, sorry, but is the Victus, the femtosecond laser used, but also with Lensex, you can put the design, the capsulorhexis, centered in the apex of the crystalline. And this is a very important issue, because this will be the position, the final position of the lens. The lens will be centered in the capsular bag. So it's important that the capsular axis could be centered not in the pupil, but in the apex of the crystalline. And with those femtosecond lasers, you can do that. And also an important other step of the surgery is the fragmentation, especially for heart nucleus. I think it's a very useful technique because several studies, several meta-analyses have shown that by using a femtosecond laser technology, the phacoemulsification time is clearly.
Yeah, Montserrat, just 1 second. Let me answer that. I think that's very important. The question everybody said to inject dispersive viscoelastic, and as you can see there, what the surgeon did was very interesting and something we can discuss in the future. And he didn't even insert viscoelastic because everything was perfect. The incision was perfect, and he just extracted the capsule without inserting viscoelastic. That I think is something interesting when we use this kind of technology. That even the normal steps that we use in surgery, they can change. And now he is using a very interesting technique to do the cracking where the femto laser already did the separation of the nucleus, and he's using a very interesting technique. Dr. Bakushi, some comments about this technique or the use of femto laser? Dr. Domenico Bakushi?
Hear me? Can you hear me? Can
yes,
you hear
perfect.
me? Okay, sorry. Okay, first of all, let me thank you for the invitation. And I just want to say that we always use femtolaser for premium IOLs implantation. And we also perform the same technique, but I think that it's better to use viscoelastic before axis removal, because sometimes you can have bridge, or sometimes you can have something that you need to manage with the viscoelastic, avoiding that some tag could create a problem for the axis removal. And also, in my opinion, viscoelastic is really important to protect the endothelium when you perform the phacoemulsification, even if you have already fragmented the nucleus with the femto.
Domenico, I completely agree with you, and I think that this is a very important point. Yeah, a lot of surgeons try to save viscoelastic now for all types of for all steps of surgery, and I don't really think that this is a good idea. Yeah, you're really putting your patient at risk. Domenico completely told us about bridges that can form when you are performing femtosecond laser assisted procedure, and that is something when it works well. Yeah, then you can do that without viscoelastic. But if you have a problem and you have no viscoelastic in the eye, then you will create an even greater problem. And I think that this is not good.
Yes, I agree. Thank you. Thank you, Ramin.
Very interesting. Very interesting. So think about it. We are with amazing surgeons. So they're thinking in ahead. I really like that, right? They're what if, okay? So they're preparing for every single situation. I think that's very important to discuss. Let's go to surgery number 3. This is a surgery that's gonna make us talk a lot and discuss a lot. So let's see surgery number 3. And by seeing surgery number 3, we're gonna start an open discussion with the entire panel. Excellent. So as you can see, in this case, it's doing 2 accessory incisions, then the main incision. Now we are putting viscoelastic, and the lens doesn't look like very dense. I want to just make a point on how meticulous is the surgeon, and he's doing something very that it's common, for example, in many countries like Russia and United States, but not very common in other countries like in Latin America, from where we are. But doing a capsular rhexis with a cystotome, I just want you to see how round and how centered it is. This surgeon looks like an artist. an amazing capsular rhexis. Then doing the hydrodissection, you can see how that nucleus is completely free and rotating in the same direction. And let's see a little bit. I think something we should discuss about is the parameters. We saw it in surgery number 1. And look at this technique. I think this is an amazing technique in while you're just using the Centurion machine into the maximum potential. And you can see how, everything is completely under control, and the surgeon is very meticulous in how to deliver and when to deliver ultrasound very far away from the endothelium, very far away from the posterior capsule. And as you can see, you still have the epinucleus there to be a little bit of a shield and protect the posterior capsular rhexis, but there is no surge during the entire surgery, and the surgeon is in complete control. The nucleus was not very hard. However, I think it's a very interesting technique to discuss about how you can roll the nucleus while you're doing the ultrasound. Another important thing of this surgeon is he's doing a bimanual technique for the extraction of the cortex, and he's going to be very, very obsessive about removing everything that you have from cortex. And I think that's another point to make in premium IOLs, to go for every single opacity that you have. Can you see that in the posterior capsule? That was amazing. And then he goes to the anterior, the anterior part of the capsular rhexis to go very meticulously to remove it. I would love to put that, as one question to the panel after we finish. If you think this is important, we saw it also in surgery number 1, how important it is to remove everything when you put in a premium IOL. Then, as you can see there, that rhexis, it's almost perfect. We're gonna inject a Panoptix IOL into the back, but one of the good things is about to come, okay? So be patient and see. I like that, meticulously how you put it and how you want that IOL to envelop in the capsular bag. As you can see there, you're putting it correctly. That's a Panoptix that you're centering also with the visual axis. And then something can happen. The question to the audience, let's put the question in Zoom for the audience, is what's going to happen next? Are we going to aspirate the viscoelastic? Are we going to rotate the IOL and center it in the best way? Are we going to perform a primary posterior capsular rhexis in this specific case, or inject cohesive viscoelastic? So take 10 to 5 seconds to answer, please. We will love to see your answer. And we're going to just put again the video to see what happens next. Please, let's show the results. Veamos los resultados. Rotation of the nucleus, 46%. And there is a 38% who I think I have some information. I'm talking about a primary posterior capsular rhexis. That's exactly what you're seeing there in a very meticulous way, in a very controlled way. We need to remember that's something that we do always in pediatric cataracts, and the posterior capsule behaves completely different with those vectors from the anterior capsule. We need to understand that it's more elastic. And then you can see how the surgeon is removing some viscoelastic. The posterior rhexis is done perfectly, and we're going to put the IOL back into place. And as you can see there, a perfect outcome. We're going to have some evidence about this technique. There is some evidence. There is some surgeons around the world who have more than 1,000 cases when we talk about a posterior capsular rhexis. In these cases, for a premium IOL, in these cases, with a very soft cataract. So then I want to see all the panel now, okay, and have a little discussion. Many things happen in this case. Dr. Norbert, I would like to start with you. What do you think about the entire surgery?
Well, it's amazing. So very fine skills by the surgeon. Amazing, amazing, I think. Posterior capsulorhexis is a hot topic, you know. In pediatric cases, it's a must, of course. It depends on what kind of posterior or retinal situation there is. Can you risk unexpected cystoid macular edema in such cases? That's a big question, and this is answered almost every time.
Let's have it there. No, I like it. Perfect. Let's have it there. Cystomacular edema as one topic to discuss. I agree completely. Dr. Ramin Korambian, what are your thoughts?
Yeah, so basically the surgery was extremely well performed. Yeah, it's a highly skilled surgeon. And regarding that technique, I think if you are a very experienced surgeon, this is something that you can do. I think for the beginning surgeon, this is something that you should not do. Yeah, because it's a procedure where a lot of things can also go wrong. And what I would rather recommend is when you start surgery to perform a posterior rhexis once you have a capsular rhexis. Yeah, it's a very nice saving maneuver whenever you have a very small tear in the posterior capsule to enlarge that posterior tear to a complete posterior rhexis, and then you can still implant your premium intraocular lens. And that is, in that situation, it's very important. Yeah, if you have a patient who decided for a panoptics and you have a capsular rupture and you cannot implant that lens, that is something that you don't want to have, and the posterior capsular rhexis can help in that regard. To perform that without a tear in the capsula, in the capsule, I personally would be rather hesitant to do that. I do that very rarely in cases where there's a fibrotic posterior capsule. In such cases, then where patients would need immediate YAG laser capsulotomy, then I would really prefer to do that during the first surgery already, but not in general.
Excellent, excellent. Dr. Bekir Aslan, you had some comments? You're mute, doctor.
Okay.
There you go.
This was a very, very talented surgery. I very much agree. A great surgeon from St. Petersburg, actually. So
I like it. Now I like it. We need to start giving some clues for our audience.
Yeah, but you know, the problem here is, you know, when you put this, make posterior capsular rhexis, and in case you make a mistake with the power of the lens, and if you're going to make a lens exchange, then you may be in trouble. That's my point.
Perfect, perfect. I like that everybody has a very open mindset and thinking also about next steps. For example, of IOL rechange, right? We need to change the IOL in the future with some problem of the IOL calculation, and then we have already a posterior. That's another issue we should talk about. After we go to the evidence to keep this conversation going, Vitor Romano, some thoughts about this specific surgery?
I think it's amazing surgery. I agree that probably if you do that maneuver, sometimes you can use for some patient where you're not convinced about the biometry, you can use a CTR. And in cases you can't. But I think it's a very, very good skills surgery.
Perfect. Thank you very much. So we're going to go to the next segment right here. Let's see. Okay. There you go. So in the Academy, we have a team of colleagues that we did a lot of research together to give you a little bit of more structure when we're talking about surgery. We talk about surgery, we're used to see a video from a colleague and his opinion. You know, there is not a lot of research about surgery, and we want to talk about it. We want to talk about hierarchy in surgery. We're going to talk about evidence. So Dr. Jason Peñacock is right here with us for the second segment of the Academy. Jason, thank you for being here with us.
Hi, everyone. How are you doing? Thanks for the invitation again, Ivo. So this time, the academic corner is going to be just a little bit different. Normally, we take you through a revision of literature, and this time we wanted to give you a little bit of tools of what you can do when you're watching a video. This session was very interesting because we had different videos, but when I'm looking at a video, is this video that is this surgical video something for me to admire? Is it surgical science, or is it something for me to copy and try to do myself? Is surgery itself just art or science? And we all know that it's a little bit of both. So in order to answer this question, there's a whole concept that we have to utilize as surgeons. And this concept is evidence-based surgery. So I wanted to ask Dr. Garcia, when you think about evidence-based surgery, what comes to mind? Dr. Montserrat, are you there?
Montserrat?
Yeah, now?
Yes, so I was asking you a question. When you think about evidence-based surgery, what comes to your mind?
Oof, a difficult question because when we talk about evidence-based, in general, we talk about meta-analysis, clinical studies, prospective studies, but especially for the surgery, it's not an easy question, no, I think.
Exactly. Whenever we think about evidence-based, we also think about the studies. And when it comes to surgery, we also have to try to implement or include some of those as well. Would someone else in the panel like to comment something about this? What comes to mind when you hear the words evidence-based surgery? Maybe Dr. Kamani?
Yeah, so basically when it comes to the safety of the surgery, I think that these days we do have some parameters that we could assess. Yeah, for example, it makes a lot of sense in my opinion. Yeah, if you operate a lot of cases during one day, to also have a look at your phaco machine. Yeah, how much phaco energy are you really using in every patient? And there are certainly surgeons using a lot of more phacoemulsification energy than other surgeons. Yeah, so this is something where you could really optimize your settings if you are noticing that you are using too much of that energy. Another thing that I think that is very crucial, yeah, even if you are a beginning surgeon, it's very important after surgery to look at your results. Yeah, I oftentimes see surgeons that are who are interested in implanting premium intraocular lenses, and then I tell them, yeah, what's your surgically induced astigmatism, and they have never looked at that. Yeah, and when you want to target for such a premium intraocular lens, obviously this is something that you have to know in advance. Yeah, so this is also a step of surgery which you could evaluate after surgery.
Fantastic. So looking at results, making sure that you reevaluate. I see the hand of Dr. Aslan. Would you like to comment something here?
Yes, please. Well, this is a great question. Evidence-based surgery for me has two ways. The evidence I put myself, that I get it from the information I get during the surgery, and the evidence I get from the others.
Yes.
These are two crucial points. For instance, the others have put forward that temporal incision is astigmatically neutral. So we know that, and it has been proven by many others. And this is something evidence. And all the vector analysis make these estimates for the toric IOLs with a neutral incision. So when I understand from the literature evidence that when I make my incision temporally, I know that I have a neutral incision and I'm going to have a vector analysis properly. That is number one.
That's fantastic. Sorry, go ahead.
Yeah, number two is, of course, I take this evidence and I also make my own evidence. And I take all my cases at the end of the day, I watch my videos and I take my cases outcomes and then
Dr. Aslan, I'm sorry to interrupt you, but you're getting into everything that we're going to discuss for the rest of this section.
So I'm sorry, that's the way I do.
But you're absolutely right. I'm interrupting because you're right. I'm not interrupting because I don't agree with you. But if you say this right now, then I'm gonna just have to shut down the segment.
Oh, okay.
But this is fantastic, and we are gonna touch a lot of what you just mentioned. And as a definition, I like to use this one. Evidence-based surgery is the awareness of what the best evidence is and available to support our practice and what the strength of this evidence is. So it's not just knowing that there are different ways of doing something. It's not just knowing that there's research behind those things. It's like Dr. Garcia was mentioning, having a notion that there's different levels of evidence for everything. Sometimes you're talking about meta-analysis. Sometimes the evidence level that you're going to have is the opinion of experts. But if there's one thing that is true about evidence, and if there's one point that we want to make today for you guys to take home, is that evidence is the language we should all speak as surgeons. This should be our common language. We should all talk in terms of what the evidence is, not just what my feelings are about a certain procedure or technique or outcome. And this becomes especially important when we're trying to evaluate our own actions or the actions of others. And that's where we're going into the videos. So Dr. Bokusi, I wanted to ask you, how do you approach evidence-based surgery? How do you implement evidence-based surgery in your daily life?
Well, I try to improve also my practice every day. So I try to do better every day, looking at the results that I have, and I try to obtain results that derive from my everyday surgery. So after surgery, I try to apply the results that I saw in my clinic and try to improve the surgery by trying to correct the errors that I can realize in the clinic. For example, I try to modify all the parameters of my phaco machine when I perform surgery, trying to reduce the incidence of complications during the surgery. For example, I try to modify the parameters of the last piece. So when I deal with the last piece of the cataract, I try to modify and reduce all the parameters so to avoid the surge and avoid capsular break, and try to obtain a better result.
So you use the data that you produce continually in your clinic to improve what your next outcome is going to be. And that mindset is very important. That's something that we all have to keep in mind. We have to collect data so we can measure it, so we can improve upon it. If you're not collecting your data, you're never going to improve. So evidence-based surgery is about collecting data. If you want to implement it, and there's an excellent book on this that is called Evidence-Based Surgery, I think it's by Springer. It mentions this 5 steps. First, you construct a smart question of what you want to improve. Then you plan a search, a scientific search. You critically appraise whatever information you get. You apply that evidence to your practice, and then you evaluate your performance. And that's how you implement evidence-based surgery into your daily life. But today we're talking about videos. And while we're talking about these videos, we saw a few interesting things. For instance, no viscoelastic for one surgery, primary posterior capsulorhexis in a premium IOL in a different surgery. These are things that when you look at them, one of the first questions you have to ask is, okay, is this something that is good for me? Or was this just good for the surgeon that did this absolutely fantastic video? And my message to you, because we have all discussed a lot of it and the pros and cons for the specific techniques during today, my message today for you is, don't just stop at the question. Go out and do some research. We went ahead when we saw the videos and we tried to find if there was anything that supported it. And we actually found some papers. One of these papers discusses a particular surgeon that did a series of 1,000 cases and spoke about what the complications rates were. There's a recent issue in CSRTS about the whole issue is about posterior capsular rhexis. You'll find a lot of things to open your mind and to evaluate what you're doing and decide if it's the right thing for you and when is the right moment for you. Now, let's move on to the next thing. When we do, what we're trying to do today is learn about videos and learning from videos. We've seen 3 videos and we're trying to get some information from them. So I wanted to ask, let me get one of these names, Dr. Romano. Dr. Romano, when you're looking at one of your own videos, are there anything, is there anything that you pay attention to or that you try to make sure that you don't miss? How do you learn from your own videos?
Thanks, Jason. I agree with you and with Domenico. I think that the first thing is collect the data and make a question that you need. I will look at the movement of my instrument, the fluid dynamics and parameter of the phaco in particular, if I'm doing cataract surgery, and in order to optimize the surgical time and the efficiency of my surgery. But in order to have to implement my normogram, I collect the data. And in case there is a complication, that I can see what was wrong. And also for teaching it's a very powerful tool. I think it's difficult to explain without seeing a video. So having a video, it's much powerful for teaching and to understand your complication to improve your outcome.
So it's fantastic. I'm gonna have to hurry a little bit with the rest of the slides. So let me just run through them. First of all, when we look at our own videos, we have to identify our habits, collect the data. We need to eliminate waste. Waste can be movement. It can be techniques that we don't need to use. It can be a lot of different things that don't need to be done for the surgery to have a good outcome. We need to review our complications and our decision-making that led to those complications. Our goal is safety and efficiency, and we use it to set our next goal. What I'm going to do for my next surgery, how I'm going to improve in my next surgery. And if we want to talk about tools, what tools can we use to learn from our own videos? One of the best tools is having a good mentor that will sit down and analyze your own videos. It's also doing it with your peers or analyzing the videos of your peers. And I can't emphasize enough rubric-based evaluations like the OSCAR or the OSSCAR from the ICO. These are tools that can help you improve each surgery. When we're learning from videos from other people, we need to listen for pearls. We need to pay attention to the details. We need to appraise critically and methodically. And the goal here is to improve our technique or to think faster and to learn newer things. So this is what we're looking at when we're looking at different videos from other people. And tools here can be journal clubs or sessions where we meet and we discuss videos like we're doing right now. And once again, having a systematic approach using rubric-based evaluations. If you do this, you're gonna have much more profit from the videos. Finally, 8 keys to reviewing videos. Number 1, is this a demo video or a teaching video? Sometimes the video is meant to be a learning opportunity for everyone. Sometimes the video is meant to be something that is used to teach and to explain how to do a new technique. Number 2, is the video edited or not? Did they fast forward things? Did they cut on their mistakes or not? Number 3, break up the surgery into specific steps. Number 4, identify the surgical landmarks. Number 5, be mindful of instrument selection, position, and use. Whatever instruments are being used in the surgery can be helpful for not just this particular technique, but for other things for you. Memorize surgical steps and endpoints. Know when the step is done. Know when you're done with the anterior vitrectomy and when your rhexis is good enough to go. Listen for the surgeon's mindset and thought process if that's available on the video, and notice how the different difficulties are handled during the video. If you take these keys, whenever you're reviewing one of the videos, even if it's not your own or if it's from somebody else, then you're gonna have a lot more, benefits from what you're doing. I wanted to get to some other of our panel. I apologize for that right now, but if you need to read more, here are some 4 of my favorite resources. Ivo, we're short on time, so I'm getting it back to you now.
Thank you. Yes, and what Jason was showing, it's, you know, we're dedicating so much into understanding the decision making, the problem solving, the algorithms we use in surgery, but in an evidence-based way. So we're going to have a lot of content for that, for you guys in the future about that. I just want to take a very short comment because Dr. Bakusi shared this image, this amazing image actually with us, and he has a very interesting concept behind it that he wants to share with the audience.
Okay, thank you, Ivo. In this picture, I just want to show how I deal with the last piece, the last cataract piece. So, as you can see here, I pull off my left hand outside the eye just to let the phaco work with these fluidics. And I set a different phaco parameters. For example, I switched off the IP so not to have a US ultrasound when the tip is occluded. And I increased the torsional power so to let the piece erode on the edge of the tip without having occlusion and disocclusion. I also reduced the vacuum and the flow rate, and by adopting all these tools, I can deal with the last piece without be worried about movement of the posterior capsule, and by using a safer procedure to remove the last piece that sometimes is the one that gives much more problems and is the one responsible for posterior capsular rupture. So this is little tips I want to share with you.
Thank you very much. Thank you very much. And for that, we have another image right here that comes from Dr. Montserrat Garcia and has some keys about surgery number 2. We're talking about the parameters of femtosecond laser, and we're talking about the mask surgeon of surgery number 2. I think it's very close to Montserrat. You can get some idea there. And here we are showing the parameters for capsulotomy and for the lens. Also remembering that we can have parameters for the incision and arcuate incisions. But let's focus in those two. By seeing the parameters, Montserrat, what are the key concepts we can learn from that amazing machine?
Yeah, these are the parameters that we usually use with the LensX femtosecond laser. First of all, with the capsulotomy, we can choose the diameter. You can select the diameter. Generally, we perform a capsulorhexis of 5 to 5.5 millimeters. It depends also of the pupil dilation, because an important issue with when we use a femtosecond laser is that we have give some distance between the pupil and the capsulorhexis, because if they are too close, we can damage the pupil sphincter with problems after the surgery, especially with the premium IOLs, and also because we have some risk of sudden meiosis due to a sudden release of prostaglandins. So in general, we recommend this capsulotomy of 5 to 5.5 millimeters in order that the capsulorhexis overlap the 360 degrees of the IOL. Okay, and also I recommend to centrate the capsulorhexis into the apex of the crystalline. And regarding the fragmentation, we can select different patterns of cut. Generally, I use the chop fragmentations with 3 vertical cuts, but in the video we have a combination of a chop and a cylindrical design, and those patterns are very useful for the fragmentation of the nucleus, especially for very hard nucleus, in order to reduce the endothelial cell loss in these cases.
Perfect. Thank you very much. And we're going to go to the last segment. And this segment is about how we communicate and how we educate in a surgical environment. Shemaine is going to be so kind with us to talk about these concepts. They're very, very important, right? The patient is the most important item in the equation in surgery. And let's try to learn something about how we communicate and how we educate the patient in that environment. Shemaine.
Thank you, Ivo. Can you hear me okay?
Perfect.
Excellent. Thank you so much for the invitation to Ophthalmo University. I would say one of my favorite things about this series is really actually in the title of the name, Your Patient's View, as you said, because in the end, you want to put yourself in your patient's view and in your patient's shoes, as we say. So, you know, when it's time for you to have cataract surgery, you have to really think about that. So we know that right before any type of surgery, patients are really feeling fear and anxiety. And sadly, because of everything that's occurred in the world globally, right, with COVID, that fear and anxiety has increased even more. So there's really some easy things that you and your staff can do in terms of patient communication beforehand. And it kind of goes with the philosophy of the more that you know. So the more that your patients know before the surgery, it's really key. I mean, you can see some tips there. And I will say that many of you may say, yeah, I know that. Yeah, I do that already. But I think it's really important for you to audit yourself and your team and your staff to know if this is something that you're actively doing. Are you consistently doing these things? And I just think that overall, having a way to audit yourself is really important, because you want to make sure that that communication before surgery is at a really high level. So I would say that one of my favorite topics really to talk about is teamwork and high-performing teams. And I would say in my 10 years in the OR, one of my favorite examples is this clinic in Dominican Republic. So I've traveled extensively to many ORs, and the way that this OR operated was just amazing. I mean, there were some basic things that many of you, I'm sure, do, but there were some really cool tips that I kind of learned along the way. And actually, I love the interactivity of this type of format. So in the chat function, I'd love to hear from you, and I'm sure everybody else here would. So if you have any tips on improving communications with your patients or tips from the OR, please go ahead and put those in the chat. But to tell you a little bit about this clinic in the Dominican Republic that I love, like many, again, they have like a pre-surgery briefing, kind of talking a little bit about their day, the patients they're going to see, what they're going to implant, making sure that they have everything beforehand. And some of that really starts from a day or two before to make sure that they're super organized. But some of the really cool things I saw is that they have key words and code words that they use during surgery, because they may not want to say, as many of you know, in a cataract surgery, the patient is awake, and they may not want to use words that could create more fear and anxiety for the patient. So they have really code words that they've created, almost their own secret language, so that the patient may not be scared when they're saying some of these things. And they even have some hand signals, so hand signals that are outside of the sight of the patient. So I think that those were really something really cool that I saw. It was very seamless, and they also did a great job making sure that the patient was comforted. So they had, one of the nurses that was by the side, making sure that the patient was comforted, that they had the blanket, that they had any kind of anxiety. They would like hold the patient and just do like this to the patient's arm to make sure that the patient knew someone was there. And you could just really see that sense before and after the surgery of how happy the patient was. And lastly, I would say that in the OR, the atmosphere with the surgeon and the staff should be of that of a high-performing team. So I think in order for you to have a high-performing team, one of the things that needs to happen in the OR is that solo mentality of really needs to be not in the OR. It's definitely a team atmosphere. So that solo mentality really has no room in the OR. And the high level of trust and accountability also has to be there for a high-performing team. So that really comes from a team that has a shared vision
and also a learning culture. So I think today we learned a lot about some of the different tips and techniques, and you might be trying those out in your OR for the first time. You really need to make sure that your staff is on board with those things. So I think to end it, when you think about a high performing team, you really need to think of a symphony, like a orchestra, and how that's conducted. So I know due to time it went by really fast, but hopefully you got some tips and tricks, and please feel free to connect with me via LinkedIn. It was a pleasure. Thank you.
Thank you so much, Shemaine. It's so true. There is so many patients that they value the experience even more than the outcomes, right? We know that. People, like patients, know what they're gonna feel in the operating room. Some patients are not satisfied because they were cold in the operating room, or they really hurt when they did some canalization to the vein. So we need to see that entire experience. Dr. Koramnia, I would love to know if you place specific attention to this experience of the patient and how you communicate with them and with your team.
Yeah, so basically, I fully agree. Yeah, that a good surgery always is due to a good team. Yeah, you as a surgeon can be the best surgeon, but if your staff is not supporting you well enough, you are probably not going to obtain a good result. Yeah, so I fully agree. Although I was a little bit surprised that Alcon recommends to go now with a symphony. Yeah, so maybe there's some misunderstanding. Yeah, but I think that is just due to the name.
Excellent. Yeah, excellent concept. I agree 100%. Dr. Norbert, some comments from you while we're communicating and educating our patients in a surgical environment?
Yeah, of course, not only communicating, but also touching the patient's shoulder or radiating calmness to the patient is a half of success. So if you rule the situation, you can rule. You have the opportunity to rule the whole process of the surgery. So if you come and get in connection with the patient in mind, you have won the situation. So that's my opinion.
Thank you so much. Thank you so much. I agree 100%. Vito, some last comments about the patient communication?
I think, yeah, it's very important. I have a good communication before and after, but also during the surgery. I think is the main things. The patient feel that you look after him and follow during the procedure. I think is the best thing.
Thank you very much. Finally, again, guys, the guys from Custom Surgical, we have one adaptator that we have it right here for you. This not only allows you to record every single surgery, but look at this. This is amazing. This will make your phone a 4K camera, but also you can do streaming. And for example, we can be doing surgery right here in Mexico City and asking Professor Berkir Aslan for his comments in real time. So I think it's an amazing tool that you can have and use to be a better surgeon. Also, the people from Bionico, they're so kind to give $500 to the people who are assisting in these models. We not only use basic skills, but for example, we're doing the Yamane technique and we are learning a lot in a simulated environment. So I think that's great. And then as you can see there, you're gonna have some discounts on those $500. And let's go to the, I almost made a mistake, but it's coming automatic. Let's leave it there. So let's go surgery number 1. Remember, amazing surgery, use Varion, a very interesting technique, almost, scleral incision, and very, very obsessively put the VVT completely centered with the visual axis. So let's see who that surgeon was. And we have it here with us. Professor Berkir Aslan was so kind to be here with us, to help us with this amazing video that he did excellent. So doctor, since you're here, please, we would love some words from you.
Well, thank you very much for inviting us through here. This was fantastic. Thank you. I very much enjoyed it.
Tell us a little more about some 5 tips for our colleagues who are listening.
Well, the tips are very important. I can say when you are doing surgery, of course, you have to decide the location of surgery. That's crucial, and apply it consistently in all cases. Consistency is the #1 tool in surgery. Number 2, perhaps 2 is during nucleus fragmentation, remove the hard nucleus core first. Simply, this will avoid dispersing fecal energy into the delicate structures in the anterior chamber, which is also, I find, very, very beneficial. As you are emulsifying divided nucleus pieces, irrespective of the torsional or longitudinal energy you are using, avoid occlusion of the facotip. This will translate into less inflammation in the anterior chamber. And fourthly, always locate center of your lens with the visual axis. This can be achieved either using 1st and 4th Purkinje images or using a digital navigation device. And finally, don't leave the eye very hard, especially when you are implanting a toric IOL at the end of the surgery. This will distend the capsule and the lens stability is endangered, provided that you have a hermetic capsule. Thank you.
Thank you so much. What an honor to have you with us. The second surgery, it's from a great friend from Spain, and we have a colleague right here that, you know, it's her partner. So Montserrat, probably you know this amazing surgeon who we want to thank you very much for that amazing surgery. What are your comments about it?
Yeah, Laura, no, is the boss, the medical clinic. So it's a wonderful surgery, the best surgery of the evening. No, I think it's a good option to create debate about the not use of the viscoelastic in this case. And also talking about the evidence-based surgery. We have performed a study comparing the use or not using a viscoelastic in refractive lens change, and we have no statistical differences. So in cases of crystalline lens extraction, we think that is an option, but obviously when we have some complication, we must use a viscoelastic.
Excellent. Thank you so much. Yes.
I've lost the okay.
No, we're hearing you perfectly.
Okay, but I can see you. Sorry. Now here, and also an skill of this surgery. In this case, we use an anesthetic, a lidocaine, for performing the hydrodissection, because some studies have shown that this hydrodissection with an anesthetic can reduce the postoperative anterior contraction syndrome. So I think this is another issue.
No, it's great. Every tip, it's welcome here. Every tip is welcome. Thank you very much. And there's a lot of guessing in the chat, and there's been a lot of talking for surgery number 3. Before I enter number 3, I really want you to look, guys, to that guy behind me called Lisandro Carnielli. He's the mastermind of everything that is happening. We need to clap Lisandro for all the magic that is behind this. It's him. You see him. He's an amazing surgeon, and he's here with us, also doing all this effect for us. We want to thank him. And for surgery number 3, then there's a lot of guessing in the chat, and they were all correct. And Dr. Aslan already said he was from St. Petersburg, and you can see him very active in social media, and especially in Instagram. and that's Dr. Constantin Telegrin, and we want to thank him so much for the effort to put this amazing video. The quality of his videos are so good. There is always a lot of teaching, a lot of sharing knowledge, and we love that in Ophthalmo University. So we want to thank Dr. Telegrin. And finally, of course, we will wait for you for episode number 4. It's going to be great. Episode number 4 is going to be about grabbing everything together, talking the amazing colleagues, as you can see there. We're talking about the concept itself and how we can communicate better with our patients in the concepts. So right now, I want to see the panel, this amazing panel. I'm so happy today to have so many colleagues from all over the world, and I will be naming all the panelists so they can, just say a few words to say goodbye. Thank you so much for your time. We know you're very busy, and you have been here with us in so many languages. I want to thank the translators. I want to thank the ambassadors, Maria Antonia, Ivo, Dimitro. Thank you so much for being here with us all night. And let's start with Dr. Norbert. Dr. Norbert, thank you so much for being here with us. I think we accomplished the objective. We're building a big community, learning from each other. Thank you so much. You have some words for us?
Yeah, of course, it was amazing venue. I think the organization is fine and excellent. Take-home messages are of very high importance. I agree with most clues and most statements by the panelists and by the surgeons. So what for me is a very important thing, that performing a surgery is always an art, but to prepare for it, to evaluate it intraoperatively, preoperatively, and postoperatively, that is science. So I think that it was a great presentation by Mr. Panikuk. Compliment to all the surgeons and panelists. And of course to you, Ivo, for this organization.
No, I'm just a face here. There's a team so big behind me. Thank you so much, Dr. Norbert. Vito, it's a pleasure to have you here with us. We have you in the past. We wish to have you in the future. You are doing a lot of things with the SASO and a lot of things with education. Thank you so much for being here with us.
Thank you to you, Ivo, to Jason, to Lisandro, to Ophthalmo University. That's great always to collaborate with you. I think it's amazing what you put together. I think it's very important for young ophthalmologists and for everyone sharing knowledge. I think it's very important. Thank you again, and really well done.
Thank you so much, Vito. Dr. Bekir Aslan, thank you so much. We learned so much from you. We're building a big community. Thank you for your time.
Well, it was my great pleasure. Thank you very much for this invitation. I very much enjoyed being here. And I very much look forward to your programs, and I will keep an eye on your programs.
That's good. That's very good. Thank you. Thank you.
I myself benefited a lot. Thank you very much.
Well, we definitely will love to have you here back as many times as we can. Montserrat, thank you so much for being here with us. Such a pleasure.
Thank you very much, Ivo, for your invitation, and congratulations to all the speakers because this has been a great and amazing event. I think it's very important to share our knowledge in order to improve as surgeons. And so thank you so much, and continue with that.
Thank you. Dr. Koramnia, we know you're very busy, high volume surgery with many residents and a lot of research. Thank you so much for being here with us.
Yeah, thank you very much. Yeah, also from my side, it was really a pleasure to be here today. And I think that there's no better way, to learn surgery than looking, not only by yourself at your own videos, but also to look at the videos of other surgeons. Yeah, you can only improve your skills if you see techniques that have been done by others, and then you can implement what they have already experienced and to improve your own skills. So I really think that it's a great format. Thank you.
Thank you. Amazing takeaway. Yeah, it's very important. Domenico, it was a pleasure to have you here. Thank
Pleasure was mine. Thank you, Ivo, and compliments for the organization. It was an amazing, meeting, and I learned very much, and I'm very happy to share my knowledge with all my colleagues and learn from them. So very compliments to you, to Ophthalmo University. I enjoy really much for this appointment, and I will never miss the next one. Thank you. Thank you very much.
We would love to have you back. We would love to have you back.
It would be a pleasure for me.
Yeah. Thank you then again to the ambassador, to the translator. Shabain, thank you so much also for your knowledge. We're building an amazing team here, and you know, everybody learning from each other. Thank you for being with us.
Thank you so much to you and to Asaso. I really look forward to next week, and I hope that so many people can connect next week. And if you enjoyed this week, please tell your colleagues to join us for the last one where we talk about post-op.
Excellent. Okay, guys, so good night in Europe. We still have a couple of hours here in Latin America, and hope to be in touch, okay?
Bye-bye.
Cheers.
Bye-bye. Thank you.
Bye-bye.
Cheers.
Bye-bye.